Hello, a very good evening, everyone. We'll be starting in just a couple of minutes from now. A very good evening, everyone. A big hello and welcome to the fourth session of Mental Health and the Second Wave, a NEESAMA webinar series supported by Samvad. An overview of the housekeeping rules. We will stick to the designated time of 1 hour for today's session. You will notice you have been muted by host upon entry. That's just to maintain session decorum. If you're invited to speak or ask a question, you will be unmuted. I request you to please start putting in your questions in the chat box as the session proceeds. For the benefit of both the panelists and the audience, I will be summarizing and clubbing questions so that we can cover as many as possible. Well, before we get into the session, it's my pleasant duty to introduce you to the expert panelists joining us today. Professor Paulomi M. Sudhir is consultant, Behavioral Medicine Unit, the Department of Clinical Psychology at the National Institute of Mental Health and Neurosciences in Bangalore, India. Dr. Udina Ategale is consultant, child and adolescent psychiatrist at the Colombo South Teaching Hospital in Kalubovilla, Sri Lanka. And finally, Professor Sultana Aljan is consultant OCD clinic and geriatric clinic at the Department of Psychiatry, Bangabandhu Sheikh Mujib Medical University, Hospital, Dhaka, Bangladesh. Well, all our three panelists have decades of clinical experience in evaluating, diagnosing, treating, and researching patients with OCD across child, adolescent, adult, and elderly age groups. However, in the session, we are not just going to be focusing on the clinical diagnosis of OCD. Rather, our examination of today's theme will transcend the normative, the transitional, and clinical realms of the phenomena of obsessiveness and compulsiveness. So we're going to move beyond OCD to something that probably all of us have experienced at some point. That is the tendency to be obsessive, the tendency to be compulsive, especially in the context of the protective behavioral repertoire that this pandemic has, forced us to adopt. So, to briefly introduce to you, what I mean by this word salad and what the scope of today's session is going to be. Now, I've been showing this again and again through multiple sessions, just to reiterate that it is mental health that is probably going to be the longest lasting wave of the impact of the COVID-19 pandemic. So whether it is from bereavement or loss, whether it is from the social restrictions that have come in, the impact on child development. So no matter what aspect you take, mental health is, perhaps, going to be the longest bearing brunt of the pandemic. But now we also know that, we've all been following some rules, we've been practicing certain behaviors, that is to keep ourselves safe from COVID-19, to avoid getting the infection. And what do these behaviors ask us to do? They're basically saying, clean again and again, watch where you are, how far you are from people when you're, interacting with them, avoid certain things. So all in all, it does sound like the pandemic, is asking us to be constantly preoccupied. And unfortunately, the preoccupations are, of course, not pleasant. They're either illness related. So how do I avoid illness? So that's what I need to be constantly concerned and aware about. Preoccupations about myself, where I am, who I am with, how am I talking, am I masked or not? So preoccupations about the self and about other people, whether in the family or outside. So the entire experience has been, something that has forced us to repeatedly think about particular behaviors and, normal practices and patterns of how we go about our daily lives. So now, considering those preoccupations and, perhaps adaptive preoccupations in that sense, and then we look at, what the clinicians in today's session are going to be aware about. So we very frequently come across something called obsessive compulsive disorder or the anancastic personality disorder, where again, and sorry for the wordy slide, but that's just how our diagnostic criteria are. There are lots of words. So whether you look at OCD, which has, again, repetitive thoughts and behaviors that are time consuming, that are very distressing, or you have the anancastic personality, where there is a tendency to be preoccupied with rules, with order, with task completion, with productivity. So, so this is the clinical end of the spectrum of, being constantly preoccupied by any or, few things. So what happens when we, try to view both of these ends together? And so basically what we're talking about is the COVID-19 pandemic has brought in, a lot of concern for cleanliness and sanitization, some amount of hoarding, we're stocking up things constantly, fear of going into another lockdown. We're ruminating, we're worried. We have to redefine rules, and rules about everything, about social behavior, about, how we stay inside the house, outside the house. And so all of this seems to be bordering upon obsessiveness and compulsiveness. But now the question here is that what is normal obsessiveness and compulsiveness? What is adaptive? So obviously all of us had some degree of obsessiveness and compulsiveness. And then the pandemic came, and then we had to do certain things in order to stay well in the pandemic. So that was probably an adaptive increase. And then, going on to the problematic obsessive compulsive behaviors, which is where, the clinical end of the spectrum comes in. And is there actually, can a person actually transition, through the spectrum because of the pandemic? Can a person actually transition through this because of everything that they are asked to do, in order to deal with this pandemic? And so this is, basically the thought that has been behind keeping this particular session on, is COVID-19 increasing OCD? And as we go through the session, I'm sure through your questions as well, we will get a chance to look at more and more aspects of this question. So with that brief overview, let me now invite my first panelist, Dr. Sultana Aljan, to respond to the theme and share with us her experiences.
Hello.
Hello, madam.
Hello, everyone.
Hi.
Yeah, good evening, everybody. Thanks to Samvad and NEESAMA for inviting me as panelist. And fourth session of mental health and second wave webinar series. Timely projected topic for discussion. Hello.
We're
Hello.
not able to hear
Are
you.
you hearing me?
Not very clearly.
Not clearly?
No.
Now?
Yes, it seems better.
Now, yeah?
Yeah.
Okay. Oh, okay. Good evening. Thanks to Samvad and NEESAMA for inviting me as a panelist in the fourth session of Mental Health and Second Wave webinar series. The title is COVID-19 Increasing OCD is a timely projected topic for discussion. And thanks, Isha, for your nice informative presentation. In my view, that COVID-19 safety protocol is well informed, most of the people, but the ignorance rate is quite high. We know that corona is an infectious disease. Several studies have found that an association between the existing psychiatric disorder and increased risk for COVID infection-related hospitalization, mortality, and morbidity. And the psychiatric patients are to have 3 to 3 times higher mortality rate than the general population. But the stigma makes a barrier between the people and the corona infection about properly using the mask, social distancing, and vaccination. They don't believe that all these measures will reduce the infection rate, mortality, and morbidity. They think that the COVID will not touch them. In Bangladesh, the second wave is very much aggressive now. Its position is ranking about 10th position, Bangladesh. Worst COVID hit countries among it. The death rate is increasing day by day. So to develop herd community, it requires to vaccinate the people, but it is time consuming. So implication of COVID-19 safety protocol is an emergency issue. And the prevalence is increasing in this corona period is, I think, it is true because the people are continuously under stress in these days for a long time, as they are staying at home continuously in the same environment. Their relationship among the family members is up and down. The family accommodation behavior is reinforcing the OCD symptoms. Genetic factor is a factor, but the social learning is now also playing the factor for increasing the incidence of OCD. The OCD symptoms during pregnancy and postpartum period are now increased. This is increased all over this corona period because the pregnant and the postpartum patients are frequently seeing over the telepsychiatry. Most of the people, it is surprising in telemedicine over the last 15 to 16 months, I found that the patients among all the psychiatric patients, that is about 43.75% OCD cases have vitamin D deficiency. And their lowest level, I think 6.35. So whether this vitamin D deficiency is a causal factor or not about the increasing the prevalence of OCD, it need to be a researchable issue. Here, the obsessive traits and the personality disorders, they become more irritable in this period as they have to work more to adjust more with the family members. The patients become more upset, depressed, panic disorder and skin disease is also common among them. Mostly with these patients that the OCD patient with incest type of thought and images, they're suffering more, I think, as they have to spend much time with their close family members. They can't avoid them, their relatives. They cut their wrist, take the sleeping pill, they hit the forehead against the wall out of distress. And sometimes their suicidal thoughts terrify themselves and their families. And so it is a time, it is a warning sign, but it is also important that this period also helps, that is acts as a glimpse of hope that the general people, psychiatrists and physicians and allied mental health professionals are becoming more concerned about the OCD, and they are doing more webinar series in our countries also. So the parents, partners, they're becoming supportive, and they're also trying to understand the disease and giving their quality time. Thank you. Thank you.
Thank you very much, Dr. Sultana. I think what Dr. Sultana has been talking about is mostly how the pandemic is, impacting patients with OCD, those with ancastic personalities, and how, whichever aspect of COVID-19 you take, whether the safety behaviors or the social implications, they have, kind of been tougher for people who are already vulnerable because of the psychiatric morbidity. And I'm sure we're going to touch upon this more as we go through the session. Let me now cut across to Dr. Paulomi. Ma'am, if you could present your response to the theme.
Yeah, thank you, Dr. Isha, for having me on this panel discussion. Is OCD increasing in this context of COVID-19? I think you made some very relevant points at the beginning, and I was just thinking that yes, we are talking about increasing numbers in OCD, but the points that you made also seem to suggest that there is a general vulnerability in some individuals, which might predispose them to more fear-related, information, threat-related information, and subsequently their actions are largely geared towards reducing this fear. And it's interesting that in the first wave, a lot of clients actually felt very validated and reinforced when they heard the instructions about having to wash repeatedly, keeping distance. In fact, we did have some clients asking us, isn't this true that my fear of germs is very right? And now, what do you say about response prevention? So it threw a lot of challenges also for restructuring some of the beliefs. But what's also perhaps important for us to understand that what the situation of the COVID-19 pandemic has created in terms of increasing vulnerability or fear in individuals, what we know as the intolerance to uncertainty and ambiguity. And that as a general predisposition to fear, we see a lot of individuals actually with the heightened threat perception to crowds, to distances. And that unfortunately has probably reduced access to care and coming to hospitals also, because of course the lockdown is there, but they're also afraid of coming to crowded outpatients. And so we're not just talking about people who have known diagnosis of OCD, but also an increase in perhaps the anxieties of individuals related to health and uncertainty. Now, probably from the theoretical perspective, we also need to look at neuroticism and how this is sort of, a common thread across the emotional disorders that we look at. And, absolute in reaction to someone who actually develops COVID-19 in the house. We've had individuals who have then gone into a depressive episode because the worst fears have come true, that they have not been able to prevent the contagion. So with reference to OCD in particular, I would think that these cognitive, vulnerabilities are very essential to address. One is, of course, the what is written a lot about now in terms of intolerance to uncertainty and the fear of the unknown, which is quite fear of the unknown for all of us as well, because directives keep changing, variants keep changing, so we really don't know what to expect. The second is, of course, the inflated sense of responsibility, which sort of affected a lot of individuals, including healthcare workers in the first wave. And then, of course, when we're better prepared, we know that it makes a lot of difference in the second wave. But it was still not knowing whether we would take something back home. And for individuals with heightened vulnerability, this perhaps became even more difficult. The other aspect, I suppose, which is contributing to the mental health difficulties and concerns is the disruption in the routine that Dr. Sultana also pointed out, is that a lot of people are within the home. So they have no way of channelizing their interactions, which would have otherwise taken care of a lot of the rituals, a lot of the repetitive habit-like behaviors, and it would have got channelized elsewhere. But that is not happening, and there are, of course, increased emotions, negative emotions of people staying at home. So in addition to the obsessive compulsive disorder, a lot of other mental health concerns in the anxiety spectrum that has increased. The other thing I would perhaps say is, apart from who in the entire dimensions of OCD, which one of them have been affected is probably also interesting to see. Are they more washers, or are they more ones with pathological doubts, or are there combinations of both? So I think that would be again something that's important for us to see. So we haven't really had much on disgust, for example. One would expect that. I mean, this is not really probably something that lends itself to disgust, but previously we would have thought that that is a very important factor as well. So I think it has had a significant impact on mental health in terms of these predispositions. And if we don't split hairs in terms of whether it goes into this diagnostic category or the other, we do see a heightened vulnerability to emotional disorders which are unpleasant, and like you pointed out, are perhaps prolonging beyond what we thought it would end in at some point, and we were actually cheering the whole thing, but it's probably going to be long. So that, I think, also contributes to general distress. It poses a lot of challenges for interventions from my perspective, because we're not able to do the traditional ERP, not just in remote ways, but also how do you do exposure for someone whom, it's difficult to say, go, face the crowd or don't wash your hands. So norms for washing and all that we've had to relook at as therapists and clinicians also.
Thank you so much for that, ma'am. I think Dr. Udina has not yet joined us. I'm hoping he will as we proceed with the session. But if I can stay with you, ma'am. So we did, touch upon intolerance of uncertainty. To some, we had one of the panelists last time speak about that. But you mentioned two other, very important vulnerabilities in terms of an inflated sense of responsibility, and then you also touched upon disgust sensitivity. Just for the benefit of the audience, if you could talk a bit more about what these cognitive vulnerabilities mean, and what do the people who have a heightened sense of these, what kind of challenges do they face on a day-to-day basis?
So I think at the core of cognitive theories of OCD, I'm sure much of the audience is aware that inflated sense of responsibility is, I mean, finally everything boils down to, did I not take care of my family, and did I not do something correctly, and therefore I'm responsible for someone falling sick. In another context, it would be perhaps the gas stove, or it would be the geyser switch, or it would be not washing hands. And this could perhaps, as we know in cognitive models, generalize to many stimuli, not necessarily what it started off with. So it's very difficult to trace it unless you're actually interviewing the client and tracing the inflated sense of response. So all of us are responsible in a lot of ways, and we do take care of our health and that of others. But we're talking about a multifold increase in responsibility, which becomes at some point irrational, and that remains at the core of inducing a lot of anxiety and subsequent what we know as neutralizing behaviors to reduce, and which is quite natural for someone to reduce distress. We're all not quite happy being distressed. So that is at the core of inflated sense of responsibility. We also know that disgust sensitivity has come up because of a trait like sensitivity to, uh, when washers, we used to talk about contamination, germs, infection, but disgust is a much more difficult construct to not just identify, but also treat, because it's less, likely to respond to exposure, because disgust is a different kind of an emotion altogether. And so we found that in a lot of people with washing compulsions or washers, as they're called, disgust is perhaps a reason why they don't respond to the usual exposure response prevention unless we're actually targeting the element of disgust. And this has something to do with the distress tolerance also, because all of us are not made alike, and there are likely to be individual variations in that. And I think these are important. I don't know how much in this context disgust, plays a role as much as the fear of contagion. And of course, it's extended to the other oriented behaviors. And I think a lot of people who reached out to us initially through the helpline, and they were not clients, they were not patients, but they were very angry that others were not following social distancing, masks, and they would actually call and say, I'm very angry, what do I do? So I think that was an interesting phenomenon in the first phase, not so much in the second phase, because a different set of emotions now, I think.
Right. So, of course, so what you're talking about is that these cognitive vulnerabilities are probably playing out for patients with OCD, and to some extent in all of us. And then it's about managing these very specific phenomena alongside living with COVID. That's kind of needed in the present time. Let me tie this in with what Dr. Sultana was talking about. So you did mention that some patients with OCD have been experiencing exacerbations. Some people with ancastic personalities are having a more difficult time. Could you and then I think you also touched upon subtypes of the kinds of OCD symptoms that are probably having a harder time than some other types of OCD symptoms. So could I request you, Dr. Sultana, to help us understand more about what is really behind these exacerbations? So who are the patients with OCD, with ancastic personality, who are particularly having a tough time, and what are the factors that are contributing to that? Dr. Sultana?
So, there is a Ajan around my, so it may have difficult to hear the sound, maybe.
We can hear
Hello?
you clearly, Dr. Sultana.
Okay, okay. So I think that the situations, your ancestral personality or this, they're doing their activities timely, always in discipline, all these things. But as they're staying at home with the other family members, they are not following her commands or her rules and discipline. So the relationship is becoming up and down. So that is causing more distressing. The patients become easily upset. And one of the case I am telling about that she is about 16 or years old girl, and she is now always she can't see her parents talking or even laughing together. They can't. She doesn't allow them to sit together. Their personal relationship is very much difficult nowadays. Their parents cannot maintain their private relationship, personal relationship. She always guards them at night. So these sorts of problems among the patient and the family members are suffering. The religious behavior is also problematic nowadays. So there is their guilty feelings, and the people are there is a increasing the morbidity and death. So there is a depression, suicidal. There is a suicidal thought is also increasing among the patients and the family members and others. Those are involved with that. So they're very much guilty feelings because that they think that they cannot notice. The parents are now realizing that they could not notice that their children or their parents before, or their partners are suffering from this type of problem before. Nowadays they become more concerned. They have the time to concern about having these symptoms, like washing is a normal phenomena, but the religious thought, incest type of thought, the repeated asking, and these the children, these symptoms are not they cannot, the person OCD patients, do not usually share these symptoms with others. But nowadays they can share with their parents. They can give the time them, so they can share, and they can visit the physicians also over telemedicine. It's nowadays this telemedicine is very much helpful to the patients because they can maintain the privacy at the home. They need not to come to the chamber, so they can talk through the WhatsApp or the Viber. So they can use, and they maintain their privacy, and they can talk with their problem in the room. So all these things, I think, this type of these types of these things are plus minus of this corona period in case of OCD.
Right. Thank you so much. So, I mean, it's interesting that it's not really COVID-19 in that sense, but the social implications of COVID-19 that are probably making symptoms more apparent. So from OCD being a quiet illness in terms of, external manifestation, the person silently suffering through it. But now, because everyone's so close, everyone's, in the same room all the time, it's become that much more obvious. And you also pointed out that maybe more so in the case of children, where the repetitive asking or maybe, things like rewriting or erasing again and again, those may not have been actually directly observed by parents, given the structures that we were following earlier. So thank you for pointing that out. Well, Dr. Udina has now joined us, and I must say timely so, because Dr. Sultana was just talking about children and adolescents. So Dr. Udina, if I can invite you to give your response to the theme and maybe specifically focus on COVID-19 and OCD in children and adolescents.
Thank you, Isha. So I think what happens in children is that mostly in younger children, I mean, a clear diagnosis of OCD becomes difficult sometimes. They usually come to us with obsessiveness, which is problematic for them, and we help them in any case. So I think the issue is, which is kind of an exacerbation of the issue with adults as well. Children usually find it difficult to, connect that their thoughts are their own, that it's in response to something, and that the consequences probably tend to kind of exacerbate the distress of the thoughts. So making these connections are a bit difficult for children. And I think we've seen that with COVID as well, identifying whether COVID-19 is directly linked to exacerbations in OCD or not. We've seen a rise in the numbers, but I think one of the main contributors is probably because with the repeated lockdowns, travel restrictions, lots of parents and children have been unable to come for treatment, be it behavioral or cognitive or the therapeutic needs or medicine. So we've seen a lot of discontinuations, and that could be a major reason why we're seeing increase in OCD numbers. I mean, another thing is children also go through something called, something like magical thinking, kind of very concrete kind of thinking. So, if my neighbor got COVID-19, it's not a matter of I might get COVID-19, but I will get COVID-19. So that builds up a lot of stress in children as well. And logical arguments, especially say around 5-7 years, logical arguments showing probabilities usually work less, whereas they probably require a sense of kind of a security. Now, the sense of security also manifests in ways like we've seen that some children, when the world around them is difficult to control, it's becoming unpredictable. They might control the things that they can control. Maybe which behavior that can manifest as obsessive behavior. So as a way of maybe gaining a sense of predictability and security as well. So I think this providing them with a sense of security is a major theme when working with children with OCD, especially in this time. And I think another point actually I wanted to discuss was, I think in Sri Lanka, I think mainly economic issues are also very prominent with the lockdowns and OCD, which tends to kind of add a lot of stress to the family system, especially parents who are now faced with a sense of unpredictability and are dealing with this stress and are kind of maybe unable to provide a sense of security psychologically to their children, whereas they were able to before when they were under less stress. So that also kind of contributes probably to children finding it difficult, having difficulties in this time. And I think also when I was discussing about treatment discontinuations, I think we have a kind of a group of patients who are children, so whole families who kind of come to us regularly, just to get some reassurance, sort out some problems they have with their thoughts, but mostly to get some sense of security in face-to-face consultation. So I think a lack of face-to-face consultations also kind of maybe contribute to this. Video consultations are good, but they don't quite provide the same sense of, being there with them. So maybe that also is contributing. So those are my initial thoughts.
Thank you for that, Dr. Dina. I think something very interesting that you brought out was, so the entire experience of predictability and security, so in the younger you are, the predictability and security needs can very often look like, obsessive compulsive behaviors, because, there is a repetitiveness to that. Children will ask for things again and again, reassure themselves again and again, and that can, sometimes actually start looking like OCD, whereas that may be a normative expression of their psychological needs. So, and since we're still on talking about OCD as a clinical phenomena, so let me kind of get a completion on that by asking Dr. Sultana to talk about, because you also work with elderly. So what has it been like, with the elderly population? Are you seeing more or less OCD there, or, what has happened?
In elderly population, that is their known case, but a new onset among the new onset of OCD is not common, not so that much common in elderly population, but in the they have some OCD symptoms. The exerted anxiety symptoms are more, and there is some depression is common among them. But OCD symptom is not much like that. As like about 72 years old, that lady, she has OCD symptoms, but that and contamination, that was prominent. But her sister was died in this due to corona, and she and her the daughter live in London. Now she wants to go to London. That's why she became so much depressed. But that their OCD symptom is not much. That is not prominent in the elderly population. Okay, thank you.
Right. Thank you, ma'am. If I can now take one of the audience questions. So Dr. Basu from Jamshedpur in Jharkhand has asked a question, and I'm reading that out. I shall be interested to know about the clinical difference between the frequent washing behavior during COVID-19 pandemic advised by health authorities and compulsive washing characteristic of OCD. If I can take that question to Dr. Polumi.
Thank you. I think this is frequently asked as to how to distinguish, and we look at the dimension of impairment in functioning as one of the key criteria, because if it's repetitive, it's focused on reducing distress is not the only thing, but also significant in terms of the amount of interference it causes with the day-to-day functioning, and is done to the exclusivity in terms of leaving out all other daily routine and other behaviors. So that would be the first thing. And of course, the degree of anxiety and the distress is also something we need to keep in mind. And this may not exist in isolation. There are likely to be other behaviors surrounding the washing as well.
Just staying with that. So yes, when we're looking at somebody clinically and say they've been, having this for some time, so say somebody has been excessively washing for 3 or 4 months, and there, it is sometimes quite easy to, say that, yes, this is definitely impairing, or this is causing so much distress and anxiety. But how we see COVID-19 playing out, it's coming in waves. And so probably the so the COVID safety behaviors also are probably, like I think Dr. Sultana was mentioning that people tend to fluctuate in their behavioral responses as well. So if you take that, those fluctuations, so what are normative fluctuations in that sense? How frequently do they transition into pathology, or what sense do we make of the fluctuation that we see in these phenomena?
So fluctuations are also in response to external threats and the information that is being interpreted and appraised also. And so one would say that it would not have so many exacerbations and ups and downs that you're looking at, the consistent increase, and a sudden onset of OCD of just washing would also, raise my antennae and worry about whether something has been there earlier and it's been missed and it's coming all of a sudden. Also, particularly the age of the client and other factors, life stressors, losses. I think we need to look at all of that to see washing not as an isolated behavior, but washing in the context of a host of other things as well. And so if we expect that fatigue at some point occurs in response to other, COVID protocols, but here it may not go into the same system. Person may consistently wash whether the threat is there or not, because there'd be an anticipation of threat or anticipation of feared consequences. So it's more a safety or a neutralizing behavior as we talk about.
Thank you, ma'am. So in that sense, you expect washing behavior and safety behavior to kind of naturally, have an ebb and flow in terms of a normative response to the pandemic. But if something is kind of sticking on and the person is just not able to let go of those thoughts, clearly becoming constantly impairing there, it might be more indicative of pathology. So I'm going to go to another question from Jatinder and Jodhpur. And I'm going to take this to Dr. Udina. So Jatinder is asking, if we found OCD in school children, can you please suggest some methods, some coping mechanisms? How can we initially help children? So I think as a first level response while working with school children, how could one approach that?
So I think, interestingly, during this, we started this project a bit earlier. We had actually started writing a kind of a story to highlight and describe OCD. So in Sinhala, because we found that children found it very difficult to kind of understand the concept of OCD. So we tried to make it into a picture story. So we were in the process of doing this while COVID came about. And one of the, I think, the main issues with OCD and children is that they have a sense that, because they can't make sense of these thoughts and difficulty in dealing with them, they have a sense of that they are going crazy, that this is, a symptom of craziness. So that is kind of a secondary consequence. So I think if initially a sense of reassurance in a kind of a very supportive way, so that they kind of understand that these thoughts are in response to something, especially if COVID-19 is the trigger, and a sense of reassurance within a kind of a secure environment would be kind of very useful for them initially, and an explanation really, which would be targeted to their developmental age. So that's where I think that picture story kind of came in, so that they understand that these kind of problems do occur to other people as well, and I'm not the only one, because that's also a major kind of a component for children. They think that I'm the only one who has this issue with thoughts, I need to keep it secret. Just knowing that other people also deal with these things, and that there is a kind of resolution to it as well. So those two as a kind of an initial thing. But I think if things are difficult for them at school, and as I think was discussed, their level of functioning is being affected, and there are secondary issues that, because of these features, they avoid school or maybe going outside of the house. I think then maybe a referral to a health professional, considering and to consider other therapies and medicine would be warranted.
Right. So again, addressing more basic needs before moving on to the clinical handling of any obsessive compulsive phenomena in children. Well, Migita De Cruz from NIMHANS has shared that. So what she writes is that we had a very late onset OCD with contamination obsessions and washing and checking compulsions at the geriatric clinic. The content almost exclusively revolved around the COVID-19 pandemic. Mikita, are you able to hear me? If I can invite you to actually share with us a little more detail about that. So what did this person actually complain of? Migita?
Uh, Um, am I audible?
Yes, you're audible.
Oh, okay. So I think this case was interesting because it follows some of the details discussed today. This was a 65-year-old man who, again, was somebody who was very anxious as a child, had insecure attachment patterns, had a subsyndromal um, tendency to wash and clean slightly more than normal. And then what did happen was that he became very, very anxious during the pandemic, began consuming a large amount of information about COVID-19. So he had to have the TV on all the time. He had to be up to date about the exact number of cases in Karnataka, in Bangalore. And from then it evolved into washing, checking, proxy compulsions, making sure that everybody sanitizes enough, and so on. Interestingly, this is probably somebody who had an OCPD and perhaps anxious avoidant traits, and had subsyndromal OCD right from his adolescence to early adulthood, which in the context of the pandemic became a syndromal disease.
Thank you for that. Dr. Paul B. Ma'am, could I invite you? So, because you introduced us to the cognitive vulnerabilities, and Nikita has, pinpointed several vulnerabilities in this individual. Could you help us, understand how this might have probably transitioned, and what possibly could be the like a cognitive behavioral analysis of what might have actually played out?
So I think Nikita's the client is interesting because he has all the vulnerabilities that you would expect with the right conducive environment of a critical situation like the COVID-19 can trigger off what was subclinical phenomena, because this is large enough for not being able to control the environment or control the situation. So we often see that there are underlying dormant beliefs about vulnerability, about wanting to be safe, wanting to, and there's anxiety as underlying phenomena which is likely to increase perception of threat, because we know it could be functional, it could be adaptive. It probably started off as that. But what's interesting in this client is also the maintaining factors, because I'm sure Nigita and team would have looked at how much information he's consuming in order to be certain that he's make sure that the cases, how many cases there are, and that might have again regulated some of his behaviors of going out, controlling others at home if they are going out. We've had a lot of elderly clients who've controlled their spouse or family members and not allowing them to go out at all. So there is a transition from what might have been a dormant phenomena or beliefs about threat and safety, and he would have had sufficient control over his environment. But here is an experience or a calamity sort of thing which is beyond everybody's control, and so there is what we call activation or reactivation of assumptions of helplessness, vulnerability, and so on. What you see perhaps in treatment might be the managing of the maintaining factors rather than just the vulnerability, because that's sometimes difficult to target altogether, but aligning to more helpful information, cutting down on reading about, we've done that with a lot of clients, asking them not to read about news and so on. And that might actually reduce threat in this individual. I would also think Nigita and team would have done something about arousal reduction if that would have helped. And if this person had worries and ruminations, that may require target also. So a lot of these are transdiagnostic. They're not specific to one diagnosis, but they indicate heightened vulnerability, and we stick to safe things and predictable things. We try to do the same thing again and again so that we feel safe also, and that's how I would understand this individual as well. So information hoarding, I think, is something that is doing to feel safe.
Yeah, that's interesting, and I've always wondered, especially when you say so you suggest something like don't watch the news, keep yourself, away from newspapers and things. That must be a difficult thing for, clients to even begin
Yeah.
to implement.
But not as in a complete no, because they're going to, I mean, they need to understand what is the reason. If you give a directive, say don't watch news at all, it's highly impossible to do it when the news feed is constant, almost on the phone or, social media and so on. So if it's possible, because in the beginning of such a heightened sense of anxiety, it's probably difficult to make sense of all the information that's pouring out and even to understand any other ways of processing this anxiety. But if they're able to understand that, it's worsening, so the socializing the person into why we are asking them not to do this, how to, spend time otherwise, and have them participate in this intervention would be important, rather than just prescribing saying don't watch news or don't watch television.
Thank you, ma'am. So Dr. Preeti Galgali has shared that we have seen an increase in obsessive sexual thoughts in adolescents, an obsession with internet safety issues like the email account getting hacked and compulsive checking, and with internet gaming, and even with Rubik's Cube in one case. The Rubik case was given by parents to keep the adolescent occupied during the lockdown. How do we manage such cases? I'm going to invite Dr. Preeti Galgali to share a little more about maybe the Rubik's case. So what exactly happened there? If you can hear me, Dr. Galgali.
Yes, I can.
Yes.
I can. Yeah. So this was a 10th standard student, and the parents thought that, to keep him away from the mobile games, they gave him this Rubik Cube to play. And that was happened in the first lockdown. But he kind of got so obsessed with it that the first thing when he got up in the morning, he demanded the Rubik Cube. And he would not only continue to play, but he would even shoot his videos, and even all his YouTube search was all related to Rubik gaming. And to the extent that he stopped attending his online classes also. So the online classes used to be on, and he had another window where he was watching these Rubik Cube videos. And this has been really, yes, it has become a bit too much in the second lockdown, is what the parents say.
Right. So I think somewhere we are finally transitioning into OCD to obsessiveness and compulsiveness. And that's interesting to see. I'm going to get in Dr. Udina's response to this. So this is adolescent. And I mean, let me just warn you that this has been a question session after session. Children and technology, children and the internet. So we'd love to hear your response on this.
Yes, that sounds like a very interesting, but also very complicated and difficult problem you have there. And I think we are also getting a lot of issues with related to adolescents, especially, and gaming, internet use, especially with online education being highlighted these days. I think what we can do is with this kind of internet gaming disorder kind of issues, there's a lot of that the issue revolves around a kind of a need for to do something and be instantly rewarded by what you do. So internet games usually provide that. You shoot somebody and you're instantly rewarded by a graphic description of points, or see something violent. The Rubik's Cube also is in a way does provide that, but also I was thinking that sometimes when you do get it wrong, it takes a lot of patience to recorrect yourself and do it again. So it seems to be alike in a sense, but also different in a sense. What we also see is, the concept of OCD spectrum disorders, where you get both the impulsive kind of disorders, where you continue to do something in spite of the consequences, and the compulsive things, where you do something knowing that you don't really need to do it. So a mixture of these kind of things. So those are kind of thoughts that came into my mind. But as what to do, I think that would probably need a lot of background information as well. But one idea is repetitiveness can also be very stressful. Unpredictability, and then I think repetitiveness is also very stressful. And in my experience, I've seen that children who get caught up in this repetitiveness find some security in it, but also find it very stressful, and they get very agitated sometimes as well. So I think kind of a solution that I kind of talk with parents is that provide some kind of variability within predictability in their day-to-day lives. So they have some kind of things to look forward to, but within predictability, but it is different things. Yes.
Thank you. I think that's a really great suggestion. So, I mean, we very often talk about structuring children's routines. So they're at home, so they must have a structure. They must, do certain things morning, afternoon, and night. But what you're saying about this needs to come in with novelty. It needs to come in with excitement. It needs to come in with, a lot of reward, and then the structuring may actually work. So certainly a great suggestion. Thank you for that, Dr. Udina. Nimisha Tiwari has a question: when to seek help as struggling with OCD, because it may be difficult to know whether it's OCD or protection from corona. So I think this is related to what Dr. Polemy earlier touched upon, that if there is associated anxiety, distress, impairment, then that is where you're actually making the transition. But I'm also going to ask Dr. Sultana if she would like to add any perspective to that. Dr. Sultana, are you able to hear me? Okay, there may be a, yeah, I think she's there. Dr. Sultana? Yeah. Can you hear me? Okay. Dr. Udina, would you like to add anything to it, looking at it from, because you have been speaking about children not being really aware of, obsessions and compulsions per se. So also when we try to assess anxiety, distress, impairment, that again, can be a little complicated when it comes to children and adolescents with OCD. So would you like to, respond to that? How do you distinguish normal response to OCD, to corona versus clinical OCD?
That's difficult, right? Again, I think whether it impairs their functionality, the level of distress, and how it affects their day-to-day lives is a good indication of whether we need to help, whether it is related to COVID or not. I think in children, I think what in my experience, I think the threshold would be, rather than knowing whether it is OCD or not, knowing whether we need to help or not. Is a kind of an important thing. So that makes it easier for us as well when diagnosis is difficult, and we start helping and use that as a base, and then slowly try and unravel things and try to find the diagnosis and different ways of helping. So with identifying thoughts, consequences, this repetitiveness, and then I'm suppressing these thoughts, those kind of things are sometimes difficult to unravel with children, because they themselves don't kind of either don't have the expressive capacity, or they have not had the are not at a level to introspect and understand these kind of things. So that being so, that again gives us a target to kind of help them. So helping them reflect, introspect, understanding the connections between these things is an important part of how you kind of help them, and that kind of usually takes time when you're working with them, but it's also rewarding, because they actually do realize these things if you can approach this with a method that actually is acceptable for them and they do understand. So you might have to be imaginative in the way you actually approach this. So you've got the CBT model out there, but how you actually work with each child might be different. So that's an idea.
Right. So understand whether the child needs help, and then get started with that first, and then perhaps go into more clarification. Mikita has shared what they actually did with the elderly client who had come to them, and I'm going to share that with the audience. So Mikita says this person in question responded well to a trial of escitalopram. He had never been treated earlier with any SSRI or another drug. So he responded well to a trial of escitalopram and cognitive behavior therapy. Of course, avoiding the news was part of his ERP. Well done on that. We did have to revisit psychoeducation periodically because many of his OC behaviors had served him well in the past. I think something that Dr. Polamy was also touching upon repeatedly. So I know we're almost at 1 hour, but before we get to the very end, I'm going to ask each of the panelists to, especially Dr. Polamy, ma'am, you were talking about how some parts of the work that you do with OCD patients have become more challenging, especially designing certain kinds of behavioral experiments, etc. So, are there is there some very conscious change, that you have in your practice that you have started doing when you see patients with OCD, patients with anarchistic personality? So is there something very consciously, palpably different about CBT being done now in this realm versus earlier?
Apart from the practical difficulties, because actual real life exposures for us also, our anxieties are also high, and I think we can relate to their anxieties even better now. So apart from that, I think understanding the context in which the anxiety has arisen and the restructuring component of the content, and I think like Dr. Odena mentioned, the individualizing the content of CBT has been very important. So it's not one size fits all, and it's also appropriate to what they've come with. So if there has been a family member who's been tested positive versus someone who is working, somebody in the family is going out frequently and not following. So we have to look at the content, and we've had a lot of clients who had health anxiety which has peaked at this point. And so we've had to restructure information, provide that. But negotiation, I think, has been very important rather than insisting upon the ERP traditionally that we do. A lot of it has also been gentle negotiation and persuasion that I think has taken more front stage now than ever before. And we've not really been able to do a lot of practical ERP because of the modality of in which we're doing the therapy also. So I think those are some of the changes that we've seen. And children, of course, we've had not many referrals because of the fact that they're not coming very much, but yeah, parents have been reaching out to us.
Thank you, ma'am. Dr. Sultana, are you able to hear me now? I think we still don't have it. So, Dr. Odena, conscious changes in practice during COVID-19, post-COVID-19?
Now that you actually ask, I think, and from what Professor Polamy ended with, I think because we have limited time to spend with children, considering our own obsessiveness and worries about OCD, reasonable or not, I think what I have in my own experience and my small team has tried to do is work with the parents more, so that some of what we actually talk of during their contact with us, they are able to kind of translate into when they're with their children alone at home. So some aspects of that security, as well as aspects of how to work with the OCD. So working more with families as a whole, and also I think there has been kind of probably moving more towards medicine a bit more, just so that because you don't have a lot of time as you would usually have.
Right. Thank you for that. I think both of you touched upon the importance of the context and, really working with the unit rather than just with this person, because COVID-19 has impacted, well, the entire world and also the entire family. So, we have to keep that, we have to take that into account as we plan individual interventions as well. Dr. Sultana, you're unmuted. So are you able to hear me?
Yeah, I'm hearing you.
Wonderful. So if I can get your response to, so are there conscious changes in practice that you are now doing, depending upon the COVID-19 context?
In this context, I think always believe that the OCD is mainly an organic disease. So it's mainly I think with medications in this, as this COVID situation is a lengthy process, when it will end, we do not know. So it causes anxiety and depressions and lots of comorbidities in this. So those are taking in this time, the most people, irrespective of age and sex, they spend time with electronics at night. They change their sleeping pattern, their meal time. They do not taking their medicine properly or timely. They're refusing that they will take at night, in the morning, whenever they want to, whenever they want to wish it. So there's an increasing relapse, and these also act as a precipitating factors. So I think the regular, we are practicing that. I like to ensure the patients and the parents, so ensure taking the medications and just sleep at time, not after 12 o'clock. And if whatever you do, the mobile or any relaxation or anything, do it in the morning, in the in daylight, not after midnight. So give the quality time with the family members, so the anxiety will be shared, and they will become more understandable and cooperative with each other. And I think so. And as the relaxation therapy is also important, I can share with them that they can do the breathing exercise in their at their home also. And the psychoeducation is very much important. And I also advise about the eating food habit. The food habit, that is those foods increase the serotonin level. That I advise them to take them regularly and avoid the alcohol, then cold drinks, eating sweets. Because one of my patients, their two brothers, they always take the cold drinks. Whenever they take about 11, 12 bottle in a day, and they become excited and the symptom increase. And these patients 2 days back, that initially she was OCD, but now presented with OCD with bipolar manic phase. And that is I think that is also a precipitating factor. And in case that vitamin D, I think in my practice it is found that vitamin D is one of the major cause, because we are all now living in the room, not going to the sunlight. So it may be one of the factors causing the distress or the increase the anxiety in the OCD person. So I am regularly giving the investigations, and if they needed, then giving the vitamin D for them. Thank you.
Thank you, Dr. Sultana. So, yes, I think that this issue of emotional behavioral regulation that Dr. Sultana is talking about, it's not just the OCD, but it's also about how your day is structured. Are you following a routine yourself? Because all of that actually helps in, actually moderating the anxiety to a large degree, and, family quality time and everything that you touched upon. I think very, very important areas to look at in individual patients that we see. Well, with that, it actually brings us to the end of this session. I think we've had some great questions from the audience, and likewise, the responses from the panelists have, of course, been very insightful and thought-provoking for all of us. So, Dr. Paulomi, Dr. Sultana, Dr. Udina, thank you very much for joining us on the session today. Thank you to the audience for being around as usual for the whole time and for coming in with your questions. We will be having one last session in this NEESAMA webinar series. That session is going to be about a study that was done about coping with COVID. We will be sharing the details of that session in terms of the date, time, speaker, and all the other details we'll be sharing with you soon. So please keep checking your emails, and we will meet again very soon. Thank you very much for joining us today. Bye.
Thank you, Dr. Isha.
Thank you.
Thank you.
Thank you.